All right, my name is Angela, guys. I am a physical therapist. Got my doctorate at University of St. Augustine and just been practicing now for like 2 months. So I'm still really fresh into this, but very passionate about it and love working with athletic population. But also just think that it'd be great if everyone isn't in pain while they're doing some specific movements that we need, right? So the first thing we're going to talk about today in this in-service is low back pain. Where is it coming from and why is it so prevalent? And then also I would love for this to be kind of open discussion. So if at any point you have a question, we can stop and chat and talk about it. We don't have to leave it all towards the end, okay? All right, so what you guys see right here, it's a clinical practice guideline. So everything that we do really should be evidence-based. So as a physical therapist, this is kind of where you're getting all your low back pain resources from. Obviously, you can reach out into different things as well, but this is definitely where we kind of would start and always just find the baseline of why and where root causes of back pain are coming from. So here right now, research says that there's a high prevalence, about 70 to 80% of people by the age of 20 are having recurrent back pain. So how can we as physical therapists and personal trainers really just try to manage and fix this? So understanding the different classifications and root causes of back pain is going to be super important. It can be a mobility impairment. That can be in the thoracic spine, in the lumbar spine, or in the SI region. People also have referring or radiating pain, so they say they feel it in their back, but sometimes they're complaining about their symptoms being more down their leg. Generalized pain, which that I think is our most confusing one. They don't really have other symptoms other than, oh, this hurts, and it's kind of something that you have to break down and really assess, reassess, and kind of figure out where everything's coming from. We have things like spinal instabilities. Flat back syndrome. Do you guys know what flat back syndrome is? No? Okay. So something with PT that's super important is that I'm looking structurally how someone is, right? I'm looking at them from this way, I'm looking at them from the side, and then from the back as well. So someone with flat back is going to kind of have that posterior pelvic tilt, which normally it's more common to have an anterior, right? But a posterior pelvic tilt here, now we think about all the muscles that are lengthened. So our glutes are lengthened, our low back as well. It doesn't have that tension that we want to be able to do some certain movements. So they have this right here. You think about that kind of patient trying to do an RDL or trying to do a squat. They don't have the right muscle length tension on all these muscles back here. So they don't even have the right neuromuscular control and that motor control that we want, right? So if we just keep throwing them exercises and we don't even realize, wow, this is how they're standing, it's like we're just throwing fire and like throwing flame to the fire without actually really addressing something that's structural. Go, yeah.
Can you make a video that has that? Rate that fast.
Yeah, you probably has closer to flat back.
Yeah. So I could give like a better image of it, but it really is like there is no lordotic curve. So it's literally under like this, right? And that's something that I'm looking at right when I have someone with low back pain come in. So that's something that we can even like kind of teach, like you guys can start looking for those things if it's not something that you look at naturally. And then we can just kind of feed off like, how do I look for this? Where do I look for things at the knees, the hips, and things like that? But in PT school, that's like obviously what they teach us a lot. And then obviously sciatica. I don't know if you guys have a lot of people that come in here and they say, I have burning and tingling down my leg. So there's different things that we can kind of teach them on how to just address those kind of problems. And then another big one is displacement of intervertebral disc. So that's people that say, I have a bulging disc. I just got an MRI, my L1 to L5. The doctor said that it's bulging, which I hate that word because in their head immediately, that sounds awful, right? And then that's just not a good way to even start their day of exercises if they think they have that. So I'm going to go into some outcome measures that we use as PTs. Some of these I think are things that you guys could use as well. And that's kind of what I would love to do, is just be able to mesh it a little bit. So that's things that maybe I'm doing on an assessment with a patient or a client. I'm going to start using the word client. I'm doing an assessment with a client, but it's also things that you guys could do in the middle of a session. If there is an acute flare-up, you can be like, okay, let's maybe see where this is coming from. So segmental mobility assessment. This is something that they teach us how to do, but if they're not, people normally have their shirts on, obviously. But in an assessment, like if it's just a sports bra or something and I'm watching, or a guy watching them do this, I'm seeing how every single vertebrae is moving, right? And the way it's supposed to move is if I'm going down like this to touch my toes, I should see each segment is moving according to how I'm going down. I shouldn't see like one vertebrae just not move, and then there's hypermobility in different spots. So something that you'll notice a lot with people, you tell them to touch their toes, and then on the way back up, we'll see things like shaking and juddering, doesn't look like a smooth movement, things like that. As a PT, what I'm doing, I'm assessing that. I'm going to start palpating, kind of seeing where the problem is, and then I'm going to ask them to do something functional, whether it's a squat, an RDL, something like that. That's something that I do know, like at school they teach us, so it might be a little bit harder to, like I can obviously teach it to you guys as well, but it would be something probably that takes time to kind of like see that kind of movement and understand how that works.
I do a toe touch in our assessment, and I'm
Okay.
looking for like curvature and flatness.
Good, okay.
So like if I see like massive curvature, I'm
Right.
gonna ask them, of course, like where they're feeling it. Like
Yeah.
you're feeling this in your hamstrings.
Right.
Usually with massive curvature, you're feeling hamstring. People
Okay.
only feel their hamstrings.
Yeah.
And then when you see flat back,
Yeah.
it's usually in their thoracic a lot of times.
Okay.
Lumbar.
Yeah.
So then I'm kind of writing notes on maybe this person needs some like thoracic rotation.
Gotcha.
Right in there.
Okay, good. And when you're looking for those curvatures, is it with movement or is it static or both?
Both.
Both? Okay,
So
good.
the first one's static, and then that usually like is my path. That was what decides where I go.
Good, yeah. No, very good, yeah. So that's one of them. And then pain provocation with segmental mobility. So basically that same thing. You're gonna have them do that same thing, same movement, whether it's touch your toes or extend, and see which movement's bothering. And then, yeah, if you have the eye to see exactly maybe where that problem's happening at, like what vertebrae specifically, that's awesome, because that's honestly buy-in with a client. Like, I know exactly where that is. Because a lot of people, at least in the physical therapy world, it's they're just throwing general exercises at people. Oh, you have low back pain, I'm gonna give you the same 5, and that's just not ideal or efficient or effective at all for them. But the big thing for us to understand, because I don't know, did you say it is kind of a lot of people here do have that nerve pain? Like sciatica or things like that? Would you say people do have that? Pretty common?
Yeah.
Okay, so,
I don't think anyone right now that has.
no?
I mean,
Like it's that constant.
Dick,
Kavita, she's
I feel like
currently in
Dick has
PT.
partly that, right? Would you agree or no?
Dick? I don't know if
I
Gail.
don't know what Dick has.
Gail does get some sort of,
Yeah,
yeah.
Okay, so basically, so the importance with that, when I think the best like way to do this when I think of a combination of a physical therapist working with personal trainers is what I mentioned to you guys. It's like, okay, for example, that client has that. Okay, now we're gonna give them a certain protocol. We're gonna reassess it in 2 weeks. We're gonna see if it helped. Did it? Great. If it didn't, okay, that's fine. We can jump from that and we can fix it. But something to understand with nerve pain and stuff like that is called centralization and peripheralization. I don't know if you guys are familiar with what that means, but centralization. So for people that have a disc bulge, a lot of people that got our MRI and they did, which a lot of reasons and why a disc bulge happens is they went to pick something up, whether it was their groceries, they did a quick turn like this. So it's forward flexion and rotation. That immediately, in our older population for sure, it goes right away. And a lot of it is because they don't train in different movements, right? They just train in sagittal plane, up, down this way, and they'll train on the side. Not a lot of people train with rotation. So when that happens and you're doing something to assess, like touch down at your toes or extend, and they're like, oh yeah, that shooting pain goes down my legs, that's called peripheralization. That means right now that area in the spine is hot, it's acute, it's not staying right where we want it to. Centralization now, let's say that at first it was peripheralization, right? Your sciatic patient. They're having some sort of pinching, it's here around the SI or it's here in their piriformis. They keep doing those movements, okay, it makes it worse. Then we check 2 weeks down the line, they're like, you know what, I don't feel it down the leg as much, but it's really right here in my butt, like right in the piriformis. Now I'm kind of saying, okay, whatever we're doing is working. It's not going down the leg, it's not hot, inflamed, irritated going down the leg. We're able to kind of control it and keep it in one spot. That's kind of a good way of being able to see, like, is what I'm doing right now good, or is it's an improvement, yeah. Peripheralization? Centralized, it is centralizing, yeah. So that's something that's like good that you can see if you do notice those symptoms changing, it's like you're now aware, like, okay, that is an improvement. And because at first you might be like, well, that stinks, now it's here, like, why isn't it? So it might feel like, oh, I didn't figure it out, but no, it's like a good thing. That's kind of like a progression right there. And then the next one's a prone instability test. This they just taught us in PT school. Prone instability test, basically what you'd be doing is prone instability. Yeah, instability test. So this is something that if we were to try to come up with a lumbar or spinal stability protocol, I would probably have every client do this. So they're going to be, their torso's on the table, legs are hanging off, if that makes sense, and they're holding on, okay? So here. You're going to just press down. So if they say I have pain in my lumbar, I'm palpating all 5 vertebrae, L1, L2, L3, L4, L5. I'm feeling that. And if they're right on L3, and this is how it usually presents, they have one specific spot that bothers them. So I'm palpating on L3, L3 hurts. Now I ask them, okay, I want you to hold onto the table, lift your legs, both legs, while I'm pressing. And then if they say, oh, that doesn't hurt, that means now they're using all the ligaments in their spine, they're using all the muscles in their spine to have stability there, right? I'm still pressing like I was before, but now it doesn't bother them. That means that person would be, and there's like pretty high evidence on this, that means that person would be very good for a lumbar stability protocol. So that's like a good first thing that we would do. One part of the assessment, right? There's still a bunch of other things, like all these things I've been saying. But that's one that I would think every client would go through first, and it just gives you objective data, and they can kind of be like, they see it for themselves. They're like, wow, why did that hurt when you pressed it this way, and now when you ask me to do it a different way, I don't feel any pain. So those are just kind of some things that we would be doing with them. And then the fourth one is aberrant movement. We already kind of talked about this. Really important to assess how your patient's moving, client's moving, whether it's just touch your toes or extend your back. If I see any shaking and juddering on the way back, that's not normal, right? That looks like there's something that's not right, whether it's neuromuscular control, fine control movement, so now you're thinking about your deep stabilizers in your back. Other things, I don't know if you guys notice this, but when they're doing stuff, do you notice them use their legs to climb back up? Do you ever see things like that? Okay, so what are we thinking, I guess? Why are they doing that? That's a good question for everyone. Why do you think they're using their legs to get up?
Like it could be multiple reasons.
Okay, so what are some of them?
I would think habit.
Habit. Habit's a good one, yeah.
Fear,
Fear. Yeah.
weakness,
Weakness. So what do you think's weak if they're doing that?
their back,
Back.
their core.
Extensors, core. Yeah. What were you saying?
I said hips.
Hips, like tight hips or
Just like hip extensors.
hip extensors, like weak hip extensors?
Yeah.
Yeah. All right. Good. So yeah, those are all good ones. I'm trying to think if there was any that we didn't.
I feel like when I get like, because I used to get like spasms doing movements like that.
Yeah.
So like I would like try to prevent them.
Right. So yeah, fear and habit, I feel like would fall a lot into that. It's already happened to me, now I'm scared for it to happen again, right? Yeah, so things like that, those are good things for when you think of your clients that you have right here. Like, who's my guy that like, he's crushing it, but every time he gets up from this position, like, he kind of has to do this. Like, that's someone then that I want you to kind of be thinking of. They might really benefit from a stability protocol and stuff like that. You know what I mean? It's like little things like that they drill in our head in physical therapy school to look at. And it might be a habit for some people, so it's like, oh, that's not a big deal, but it actually is. It's because it's not normal to get up like this, right? Even if you are older, it's not like every 6-year-old or 7-year-old should now be getting up like that. Like, it's not something that's normal at all. So
That prone stability test, so is the fact that they're having pain is just based on that vertebrae, not on the muscles and ligaments around it?
no, that's the thing. It is the muscles and ligaments around it, and it's probably a disc problem. But it shows that the second that those muscles and those ligaments are being turned on, that they don't have as much pain there, because it's an unstable joint right now. Because you just touch on it and it's hot, it doesn't feel right. But the second you turn on all those muscles and you press, it's not as aggravated. Like we've done it on people in my class that did have that, and like we were pressing as hard and they were like, I don't feel it. Like it literally goes away, yeah. Which it's weird, doesn't make sense, but I mean, there's like good evidence to prove that that's a pretty solid one to use. The next thing, okay, this is another thing that I don't know if you guys do this much, but it's literally as simple as touch your toes and you're assessing someone. If you have them touch their toes, what are some things you're looking for? We said that shaking and juddering movement, coming up on their legs. What are some other things you're like trying to see or look for when you do that with them?
I'm looking for like spinal mobility.
Spinal mobility, okay.
The non-mobile parts are in the right part.
Okay,
the mobile
good.
parts are in the right part.
So another thing for us to look for there is that if someone's bending down like this, does their head stay right in between their legs, or do you notice some sort of shift, right? And if you notice some sort of shift, so to show you guys right here, if I were to bend down like this and I go to the right, what are you guys thinking in your head might be reasons that I'm shifted to the right?
Either pain.
Okay, avoid pain on the left maybe? Okay, so avoiding pain on the left could also if you want to try to think what structure might be the issue, that could be like a disc, right? A bulging disc on the left. If that thing's bulging on the left, you're going to bend to the right to avoid it, right? Training wise, you still might do the same stuff, but if you're able to like educate your patient on that and be like, hey, I do notice when you do this, you have some sort of shift to the right. And then it's almost like you're telling them what they already feel. I feel like that's like the best buy-in that I've had with people. It's like, why on the left side are you kind of more hesitant and stuff? And they're like, oh, I'm actually glad you saw that. I have a herniation on my left. And I feel like immediately they just gain so much trust, at least in the 2 months that I've been practicing. It's really been that little. But yeah, it's just immediately like you get that. So that's something really important to look at. But also, pain isn't just the only thing. Can anyone think of anything else that you might? What is it? Tightness on the right, yeah. Exactly, tightness on the right, weakness on the left. So when you think tightness on the right, it could be a muscle or a joint, right? And that's the biggest thing, is that we can't just address muscles, because for a muscle to work properly, the joint that's underneath that also has to be moving properly. If not, you're just like treating the pretty thing on the outside and you're not treating the actual cause. That's where, yeah, if you see it's like a repetitive thing, we're doing certain stretches to address that muscle tightness, which everyone here can give a good stretch for tightness on the right side of the back, right? But if we're not addressing that joint, then it's not really going to get better. That's where I was going to say that now me, that's where I'm very,
You can't really see things like that.
no, and that's where immediately I'm getting hands-on and I'm palpating at the whole spine and I'm feeling how their rotation feels like, how does their flexion feel like, and that's physical therapy school is half of that, right? Palpating at the spine and things like that. But that's where, as a team, it'd be so good. You see the muscle imbalance. You tried stretching the muscle, like you tried doing the things that you guys can do, and then you're like, it's still not 100%. And they're still doing their exercises, but they also don't feel like 100%. So it's like, well, we can figure it out. Like we can see if now it's a joint problem. And then I could easily report back and be like, yeah, it is a joint problem. Perfect. So then I start doing a little bit more joint mobs, things like that, where I'm more manual. And then you guys keep doing the exercises that are creating that stability that you still need.
What are symptoms or what are signs that you'd be able, other than having someone touch their toes, are there ways to see when someone would be struggling from an imbalance like that?
Yeah. Okay, so touching your toes, obviously that's a good one because there's no load there, right? But then if you're doing exercises like when you're squatting and stuff like that, I mean, if you see, and this is a big one that we kind of are going to talk about, that hip shift and things like that. If I start shifting to the left, clearly feel stronger on my left side. My right side is honestly basically just turning off. That's how a lot of times it's experienced. So if I'm down here, we still got to keep our extensors upright. I'm thinking immediately right multifidus isn't working well. Multifidus is one of the deepest muscles in the back. So things like a squat would be great. A hinge as well. If they can't keep here and they start opening up and stuff, I'm thinking about why are their external rotators opening them up? Why are they wanting to do all that?
That's something we really struggle with people.
Yeah, keeping the straight
back
RDL.
leg from
Yeah.
the hip, or the non-working leg hip from rotating.
Yeah, so I mean that all those movements, like your functional movements, things like that. So yeah, it doesn't just have to be touch your toes and extend. It could just be like any of the very functional exercises that you're giving them. I mean, even a bird dog, if you try to, everyone here knows what bird dogs are, right? Yeah. So when you try to have them do their bird dog, if they get here and you just see this hip drop, I mean, that's my left multifidus can't even keep my spine up, right? So I'm thinking about all that. Like, you can give them any exercise and then just kind of immediately think, okay, why is this moving? Okay, now what's the structure that's making that happen? And I love that, so like I'd even love talking about that with you guys more, like, because that's also going to teach me a lot too, because you guys probably get to see way more compensations than what I see, because as a physical therapist, I'm not working with all people that are at the level to be doing like what you guys are doing. I'm seeing a lot of people that all they can do are step ups right now, right? So it'd be like a good mix to be able to see both. The next two, straight leg raise, that's specifically sciatic pain. This one's not a big deal, but lay flat on your back. You're just holding their leg up like this. Oh, does that shoot pain down your leg? Yeah, okay, you probably have sciatic pain just because you're tensioning that nerve, right? So there's not much magic to that one right there. But number 6 here, trunk muscle power and endurance. You can kind of read some of those. I just really want to talk about the TA because that one's super important for lumbar instability. Do you guys know what a TA draw-in is? Yeah? So she said you guys call it like ribs down and pelvis up, right? Is that what you said?
Well, that's why I wasn't sure if it was the same thing.
Yeah, it is like the same thing, exactly. And you...
Like T is transverse
Transverse abdominis, yep. And when you guys have them do, so when are you guys using that? And like, why are you teaching them that, I guess?
I would think the rib cage is flared out for us.
Okay, so you see a,
Head presses, for example.
okay, so you're doing it for overhead press movements because you see them arching their back, things like that?
You see the rib cage coming out.
Okay, you see the rib cage coming out, okay.
I would say chest presses.
Chest presses when they're supine, like when they're on their back, yeah? So they're here and then they're just doing this too much, they're not tucked in? Okay, good.
Getting people to understand the difference between like keeping your spine aligned, but also keeping your shoulders down and back. 'Cause
Yeah.
a lot of times when you tell someone to pull their shoulders back, they immediately like, okay, like this.
Right, yeah.
So like just educating them on like the correct positioning of the
Yeah.
spine and the shoulders.
So you're teaching them that when they're laying on their back or when they're standing?
Both.
Both, good, very good. Yeah, so the first thing is teach it when they're laying on their back. So do you,
Easier for you?
that's exactly how you should start it, yeah. On their back because they're not standing against gravity and everything else is being hard, right? They're just now just thinking about that certain movement. Do you guys know how to feel if they're doing it right? Do you know where to feel?
You should explain it regardless.
Okay.
You probably think we do, but
Cool. So I'll usually have here laying on their back. And I'm going to do knees up just because the second they go knees down, and I'm thinking about my client population. The second they're laying knees down, they're like, oh, my back hurts just from
I think it's easier
the
to
tension.
get yourself in the right position with your
Yep, so knees bent, okay. You're here immediately. Some people are lordotic here, I am, right? So I'm telling them those things. I think that's great how you said ribs down, pelvis up. That's a good way to do it. And then here, when I'm telling them to brace their core, I use the verbiage like pretend someone's about to punch you in the stomach. In that, you guys, right.
breathe, cough,
Cough,
punch
yeah.
in the stomach, and
Okay,
if
good.
there's anything else. Oh, someone
Pull your belly
uses,
button.
Pull your belly, yeah, good.
and then someone uses like
It's a gentle version. Imagine if Tootsie is about to jump.
There you go, that's good. That's very sweet, that's good. Wait, I'm gonna start
Oh,
using
I
better
also
ones.
use, like what's it called when women wear those
Corsets.
corsets, like
So
that.
your TA is your abdominal corset. That's how they teach you, right? Okay, so now when they're laying here, if you guys are you guys want to do it on yourself, actually? Can everyone lay like this, if that's cool? And I'll explain it. So once you're here, you're getting in that position that you're telling them to get in, right? Palpate your ribs. Just feel your rib cage. Go right laterally to your ribs, and I'll come around to make sure everyone's feeling it.
right laterally.
Go laterally to your ribs. Laterally and down. Do you feel that muscle contraction? Get out of it and then get into it. Get out of it. And you're sinking, right? You're sinking because your TA is a little bit deeper. Yeah. So right under the ribs. And here I'd be, yeah, you're just shredded. Okay, cool. Yeah. All right, good. Yeah. Can't even feel anything. Can't even sink in. But you guys feel it, right? Okay, so that's the thing. And then it's good to teach them that, right? Hey, like feel this. This is what it should feel like before they do any movements.
So right below your rib cage.
Yeah, right below, exactly, right where you're touching.
Almost like they're trying to go expands 360.
Exactly. Yes, exactly. So you're telling them this, like, bring it in, right? But you should feel that TA contract right into your hands. And that's something good because when they're home and they're doing their stuff or they're out of town and they're like, oh, can you guys give me my exercise that I'm going to do at home? And if we're really focusing on lumbar stability and stuff like this, they're going to feel great when they're at home and they're like, oh, I know exactly what they told me to do and I can feel it for myself. And they'll maintain that, right? They'll maintain that position. So that's like a very important one.
I have a question.
Yeah.
So like, what about somebody that just doesn't get it?
Yeah, that's the
And
toughest.
even if you manually can do it for them, they still don't know how to do it.
Yeah. Those are the people I just have to take my time with and be more patient with and keep doing it a couple of times. But
There's nothing you would regress to even further than that.
regress to even further than that, I mean, yeah, then I'm just doing posterior pelvic tilts. So many times until they literally just start doing it on their own, right?
Like
But it's hard.
She's one of those, can I say names on camera?
Yeah, but
Kelly Ware, who, I mean, she's strong, right? She's not
Yeah.
weak, but she has a really hard time understanding when she's doing like a dead bug or any sort of like to maintain that pelvis.
Yeah.
Even yesterday or whatever day I had her, I was like, okay, let's go on with pelvic tilt. She's like, oh, it feels so good.
Yeah.
She's been trained a long time, but like
Yeah.
still really
But
benefits
she
from like
blames
that
her
micro
lordosis.
movement.
Right, yeah.
she blames it. She always like, I have lordosis.
Yeah.
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 And it's, yeah, you see it, obviously, yeah. Okay, number 7 is one that I love so much and I'm so passionate about, and there's no writing underneath it because I think it really needs its own separate day of talking.
Oh.
Yeah, no, just that. But what I'm thinking of, the way that we can make this one very beneficial here, if People don't have the right hip range of motion that they need. A lot of times it's going into their back, right? And that's a hard thing to see, but some way that you can do that functionally. Obviously, you're checking your squats. We already said squats. If there's a shift here, that doesn't look right. Let's break it down. Why is that happening? What? Use one of them? Oh, yeah, I can use one of them for this part. Yeah. Okay, so now I'll show you, but this is how I want the functional screen to happen. So this is something that you guys can use. One of y'all want to come up to be my, yeah, thanks. We're actually going to need to do this against, is it fine if we use that wall? Okay, cool. So, no, not this wall. Okay, so first thing you're having them do, yeah, sorry, I just moved everything. You're going to have them do their squat first, right? So you go ahead, come here, do your squat.
Can everybody see?
Can everyone see? I know, I picked the worst spot. Yep, do your squat. Good. Again. Awesome.
You just slow it down a little bit.
Yeah, slow it down a little bit.
We've been talking about depth over here.
All right. So what are some things we look for right away when you guys are looking at a squat?
Hip shift, hip hiking,
Hip hiking, okay.
pelvis dumping,
What's pelvis dumping? That's new to me.
Like butt wing?
Butt wink? Okay. So what does a butt wink mean?
it could be a few things.
So I have SI pain, right? I'm a female. I'll give you your client. I'm 45. I've had 3 kids already. My back hurts. They think their back hurts, right? My back hurts is this whole area. Sometimes I get weird pain down my leg, like into my butt. Is this my back or is this my SI? They're asking me, right? I'm doing all my assessments, things like that. You guys might be like, well, why does that matter? We're still probably going to treat it the same. SI and back, I think, is where you can really make it a little different. But that butt wink. So a lot of my SI clients have the butt wink. Why? It's because once they get here, they just want to they can't control that end range, right? And think about how much stress. So there's 3 ligaments that come over our SI joint right here. Think about how much stress they're putting on that ligament every time they wink their butt in that tilt's happening, right? So that's super important to cut right away. So I think that one's huge.
There's a lot of arguments on like butt wings, right? Like, oh, some people think like, no, let them do it. Some people think, don't let them do it.
Well, I do it, and I mean, I'm 27, haven't had kids yet, haven't had any other reasons really for this to be.
You're basically an infant.
Yeah, basically an infant, sure. And mine is super bad, and I had a trainer recently tell me, she was like, you don't control your end range at all. Like, you just go right at the bottom. And I'm like, well, yeah, because I feel like some apprehension right down here, and it hurts. But I feel super strong on my way up, because what do? I'm bracing, I'm contracting, I'm using everything to push up. And I have pinching pain right here, which is right on my SI all the time. And I could do so many things to do stability there, but yeah. So other things that we look for. Knees, ankles. What was it? Feet pronating. Yeah, you have that. The forward trunk lean is huge. I squat with a forward trunk lean, didn't even realize it, and I'm literally down here, and I thought my glutes are, they're super strong, I'm doing all this great. Sure, yeah, my glutes were getting strong, but my back extensors were so turned off. Wasn't even using my back extensors at all, so I just let them elongate here, and I wasn't even able to hold this position, right? So that's something huge to see with your people. If they have that really big forward trunk lean, could they maybe benefit from a stability, lumbar stability protocol, something like that. And then another thing, functional movement screen, single leg hop and land. Good, all right, good. Other leg, what? Watching what the knee's doing. You can't even talk about the hip without talking about the knee and the ankle, right? So we can't even just separate it all together. But yeah, if that knee lands like this, obviously there's genuvalgum there. We're thinking about all the structures in here that are going to continually get shot if we keep doing those movements. Not that everyone in here, do you guys have a lot of clients that are plyo, quick movement, things like that? Yeah? Great.
We coach jumping from like the very base movement, like holding onto a rack,
Right.
jumping, then not holding onto a rack, then or single leg holding on, alternating double holding on, then all those
Good.
not holding on, and then like hurdle jumping, box jumping, or just basic squat jumps.
Yeah, very good.
Things that like progressively, so you can correct things like knee
Perfect.
wrinkles, foot
Yes. Very, very good. Okay, so things like that, just a single leg hop. See how that's moving up and down the chain. And then you can also do our 90-90. I think this one's huge. Me and Heather do this one all the time. 90-90, but shoulders are against the wall. So there's no movement happening. So you're facing this way like this. Yeah. Just like this. All right, do you gues have them do this ever?
We do a lot of 90-90
Okay, now so I'm going to show you the difference. Here, I want you to go ahead. You're going to watch me do it, but yeah. You're going to internally rotate back leg, right? I'm going to have my hands like this. I'm going to internally rotate. All right? It stinks, and I'm cramping right here in my hip. I want you to try it without the wall first, how I am. And 90, so fix this. Yeah, just like that. Uh-huh. And now let's lift. Good. Again. What do you guys see? Does that look like a perfect 90-90 hip IR? Pretty solid?
Yeah, why'd you pick her?
Huh? Now go against the wall. This is going to be right here, all the way against. So I want your side. Yeah.
You know who we need to choose for that? Cole.
And then go ahead. Up. Good. Up.
You say you're getting better?
She's solid. Other side. All the way again. So this should be all the way against the wall. Yeah.
The reason for the wall is?
There are no trunk compensations. No trunk lean at all. Now go ahead. Yeah. Good. This is just hip. Yeah. She's a terrible example because she's awesome at hip internal rotation. Great. Good. Yeah. But normally you'll see a difference. Wall, no wall, it's, yeah, night and day. So someone else want to try it? Come on, Cole. Mine cramps. My left one cramps right away. Yours, IR was making it holler for sure. IR, yeah, this would for sure. You have little IR? Okay. All right, here. Let's fix this one. Good. And then here, we're 90. You okay there? I don't want you to cramp up on me. I'm sorry. Hands are crossed across chest. Good. We're completely here. Now let's lift.
I probably wouldn't be able to.
Okay, so this is an example we see a lot. Look, it's not lifting, right? Okay, so immediately, go one more time. Huh? What did you say?
I said, are you doing it yet?
Yeah, he is doing it.
Don't you see me tensing up?
Okay, now you can relax. You don't have to keep staying in that position. So the first thing I'm thinking when I see that, okay, clearly there's weakness in the IRs, right? But maybe there's tightness in the external rotators, and that's the problem. So it's not just address, okay, now we're just going to strengthen IR all day. I have to also think on my external rotators that are tight. And if those external rotators are tight, we can't have the right muscle length tension that we need with our IR to be able to do that movement, right? So it's just,
Guaranteed to be that?
huh?
If you're weak in your IR, are you guaranteed to have the
Tightness in the ER? No, that's what I'm saying. So from here, what I'm doing is now I'm having my client lay on a table, and I'm muscle length testing their external rotators.
But can we test for it?
You can. Yeah, so do your piriformis stretch, right? So lay on your back, please. So piriformis is one of our main external rotators when we're thinking deep muscles, right? With the legs straight. Once piriformis is bent, now it's doing internal rotation, right? But here, a great way to check for your external rotators. I'm here. So to stretch your external rotators, you're doing the opposite motion, right? So I'm here. I'm internally rotating the hip. Do you feel a stretch anywhere?
A little.
A little bit. Where do you feel a stretch?
Inside.
Inside the hip. Okay. So our external rotators in our hip are things like our internal rotators in our hip are pectineus, muscles that are super small. Like I can pull up a picture really quick. But really small muscles that are attached in the pelvis. Pectineus is one of them. Gracilis is one of them. They're all small and they're in here. So yeah, it's normal for them to be like, yeah, I do kind of feel something deep in my hip. If they do feel a stretch, that's great. We're going to hold it here for a bit, okay?
My IR's gotten better.
And your IR's gotten better. Awesome. Good. All right, so just things like that. What?
It used to be worse.
Yeah. All right, good. So that's so when you're thinking your stretches, right, you're just doing the opposite action of what it is. So if my internal rotators are tight, I'm then going now here into external rotation, like this. Do you feel a stretch here? Yeah, where do you feel a stretch?
Outside the hip.
Right at the outside. Okay, great. So if you want to do hands-on things with them, awesome. And then now you teach them how do you do that at home. What's one that we're doing at home? External rotator stretch that we're doing at home. Probably figure 4, probably pigeon stretch, things like that, right? Always translating it to something that they can do at home.
Considering you work a lot with vibration, how do you get someone that's willing to do a pigeon stretch?
To do a pigeon stretch? Yeah, that's great. I'm doing super true. I'm getting them on their back, doing a figure 4. That's one of these, right?
Yeah, that's what we do.
Yeah.
I can't even.
No, there's no way. And then they're like, wow, that hurts my knee. I'm like, yeah, that was silly. I'm sorry even. My fault. I shouldn't have given you that one.
Just repeat the thing about you said when you put something in flexion, your piriformis
Piriformis. Yeah, so piriformis is working as an external rotator on a straight leg. Second, you bring it up here. Now the way that the muscle is with the hip flex, it's now doing IR up here. Yeah, yeah. Thank you for being mine. But yeah, that's just like ways to do things functionally when I think about IR and ER. And then where else are we at? Interventions. Okay, so all this, what all this means, we got to work on trunk coordination, strengthening, and endurance exercises, right? So here I'm going to talk about the TA and the multifidus. You guys know what the multifidus is, right? All right, we know what muscle that is. What are some... No, we don't? Okay, so multifidus. TA, you see that picture right here. And then you guys see me highlighting putting it together. So this is just me talking basically about how we could do this and make this, I think, look great as PTs working together, personal trainers working together. Basically, like I said, you see any of those weird kind of abnormalities happening, okay, I see it, let's address it. You send it to your PT. She gives you objective data. She gives you things that you can tell your client. Your range of motion is this value when it could actually be this to be better, right? Your strength when we're doing a manual muscle test is this when really it should be a 5 out of 5. And right now you're at a 4 minus out of 5, right? So we're giving them objective values. We can do a questionnaire, which we have low back disability questionnaires that we use. You're right now at a 75% impairment. 3 weeks later, you have them check it, do the assessment again. Now they're at a 50% impairment. Cool. They're seeing there's numerical values and there's objective data showing them I am getting better, which a lot of people want to see a number, right? I mean, and it's great for them just to say I do feel better. I mean, that's also fine. But if they can see values, it's really good. Like mentally, it does help them. And then, yeah, like I said, assess, reassess. So 3 weeks down the line, I ask you guys, oh, how is that client doing? Wow, their RDL actually looks so much better. They're feeling it in the right places, things like that. Why? Because we addressed their low back. That's where like everything was starting. So that was just kind of that part. But TA, there's your picture of your TA. It tells you your attachments and things like that. Why it's so important. Look, it's all attaching in the hip. Your iliac crest, your thoracolumbar fascia, which is all that fascia in the low back where all those back muscles are attaching. Even is attaching all the way into our pubic bone. That's why it's so important. Like the hip and the back are all one unit. We can't even talk about them separately. And then your multifidus is on your next page. The most important muscle for low back stability, right? Look, that's attaching on every single vertebrae up and down the spine. You think about all the muscles that attach on top of the multifidus. What other muscles are we thinking about? Like our superficial muscles that you can't even see because, like, obviously you don't see them in this diagram, but what are all the superficial muscles on top of our multifidus when we think erectors, right? Erectors are going to be right on top of that one, right? What's lats, erectors, your lats, what else? Am I missing any? Erector, lats, rhomboids, more upper back, right? Rhomboids, maybe even think a little bit into the shoulder, your rotator cuff, right?
Where's your QL connect?
That's a huge one, huge one. So QL is going to be this little weird one I drew here. You guys see that? You guys see that? QL, you know what QL does? We know what QL does, right? Okay, so QL is going to attach L1 to L3, about that. Going to come out and attach into the iliac crest, right? Right into the hip. So a lot of people there, that was one of your...
That would be like the majority of people that have back pain, they always complain about their QLs. Otherwise, it's like, for me, it's either like here people talk about or like here.
Yeah.
Or then you're, of course, more like scap area. But
Yeah.
lumbar specifically.
Yeah.
I don't so bad I'm having this
Like
conversation with myself.
Kyle.
Kyle K. Oh, that, yeah.
So what is his situation like?
What do you pull his back and then his hamstring, or his hamstring and his back?
I think hamstring first.
Okay, yeah. So
Like pulled his hamstring and then went away for 2 weeks. Came back, basically pushed way too hard. Like rowing, yeah.
Rowing, yeah.
Like third rep on a rower, and then you just instantly popped up, and he's like low back, like riding that QL.
When he's like nauseous.
Like nauseous.
From how bad it is.
Yeah, like ready
Yeah.
to throw up.
So right when you said using the rower, I'm thinking all the muscles that you're using with that, right? So the next thing we're going to talk about, so you guys see where the multifidus is, right? I might have to hop around now just because that was a really good example. So multifidus is super deep into the spine. All the muscles that are on top of the multifidus are all of our accessory muscles, right? They're super important. Those are our global movers. They're making all the movement happen. Our local stabilizer is our multifidus, if that's how you're going to think of it. Multifidus is a local stabilizer because it's attaching in between each segment of the vertebrae. Our lats are going to skip. Like our lats, I think they attach T2 to T7 down the spine, and then they attach out into the shoulder, right? So think about, they're not all intersegmentally, like, it's not all attached how the multifidus is. Like, it's literally vertebrae after vertebrae after vertebrae. That's what you can see in this picture right here. So when you think about someone using the rower, the first movement that they're doing, I mean, what do they teach? Like, use your legs first and then let the arms come through? Yeah. But when they're in that extended position right there, if they immediately turn the lat on and they turn on the QL and they turn on their erectors before they turn on their multifidus, they're so much more prone to injury. If you don't train your multifidus that well, how do you expect it to ever turn on first, right? So a lot of things that we do as PTs, I'm having someone lay on their belly like this, and they're just doing extension, right? I'm taught how to palpate and feel the multifidus. That's, I think, hard to just like teach right away. Like I said, like it took years of us, like you start to understand what things feel like under your hands. Palpation, I think, is the biggest difference with physical therapists and like a personal trainer. Because exercises, I mean, y'all can get super creative with exercises, probably more than I can. But you're really sinking in, and if I don't feel that multifidus firing, but everything else, I mean, the back is extending, right? The muscles are working. I'm immediately like, they're going to get hurt probably when they do a lot of extension movements because they're not, the biggest stabilizer isn't doing its job. So that's something, yeah.
I have two questions.
Uh-huh.
Is there a way to tell if someone's using their multifidus or not?
Yes.
Visually? And then number two is what exercises specifically target the multifidus?
Yeah. So the way to see it visually, no, not just visually. No, you got to be able to touch it because they can still complete the movement. You get what I'm saying?
I guess then the question is, what would be symptoms that they're not using it?
Kind of like the ones that we were talking about. So when they're coming back up from here, they're the shaking and juddering. We call this lumbo-pelvic rhythm. When you come up from here down, what's happening here is you go into a posterior pelvic tilt and then your spine follows. When you go down here, you go into an anterior pelvic tilt. Your spine goes and then you go into an anterior pelvic tilt. Lumbo-pelvic rhythm is being able to see that and saying, ooh, actually on the way up, the hip's going before the spine, not the spine's going before the hip. It's like understanding those kind of movements and how that's supposed to be. Yeah, so like when you go down here, first that spine should roll and then there's an anterior pelvic tilt that happens, right? On the way up, we should have a posterior pelvic tilt, then the spine rolls. Those are things that if you're trained to see it, great, you're gonna notice that in something as simple as touching your toes. I know it's the one we keep using the most, but so that's the way that you could see it. And then exercises, yeah, for sure. We got these right here.
I mean, I have a feeling we probably already do them. I'm just curious.
Yeah, so it's co-activation, helps with spinal stability. It's our last page. But your bird dogs, your dead bugs, Palloff press, you guys do those? Standing overhead carry marches, great because you're addressing a lot of things, right? We're addressing the TA as well. And then half kneeling lifts with rotation. That's just down here, and they're doing stuff across, right? Good. And that kind of goes to say also, do you guys think you do a lot of rotary movements as well? Rotation through a lot of your exercises, not just, yeah, not just sagittal. Okay, good, because.
So I got a question for
yeah.
you. So at what point do you not give, we used to give overhead carry, but some people just can't extend overhead that well.
Because their shoulders are the problem.
So just like this instead of
Yeah,
like this, you know?
right.
It's still worth giving it to them.
Yeah, exactly.
Okay,
Or is it
so.
more of like to me a lot it's more like how much can they get there versus it's like so bad I can't watch this.
Right. Okay, so we're doing an overhead carry here. Why? Because we want the load over their head so that it forces them to use their core more. Is that kind of why you're doing an overhead carry? Or is it because you also want to use their shoulder stabilizers?
I think it's
and all of
bang
it.
for your buck. Like
Yeah.
Working shoulder stability, working.
Okay, good.
Yeah.
And then their arms aren't extending completely. At the elbow or at the shoulder? Where do you think the problem is? Both. Okay. And then if you hold it down here, is it as effective?
I mean,
I think so.
parts, but
Yeah,
not
I
for
think so. So how am I changing it? I'm regressing it. My shoulders are kind of the problem. Okay. Maybe then I'm making it two separate things. If they don't have the shoulder stability, shoulder range of motion, I'm not going to do them together. So then I'm having them against a wall, so they still have something very, like it's still difficult to complete. So now I'm saying, okay, we're taking out the shoulder. We're still going to make this hard because now you're against the wall. And that means everything at your back I want to be done perfectly fine because I'm taking out the harder thing right here, right? So now when I have them here, they're going to have the TA drawing. They're going to have a little bit of a tilt. I'm having my weights down here. I feel this so much more, and I'm compensating. Like, it's hard for me to hold this position right here, right? And I can do something if I want to include shoulders. I'm having them press their arms against the wall, so they are using their rotator cuff. Rotator cuff is turned on completely right now. Just holding this position right here is tough. I'll add a ball behind their head. I want you to be here. I want you to maintain that. You're now doing cervical retraction. You're now doing your TA drawing, posterior pelvic tilt, and my shoulders are turned on.
We call it a wall hug.
A wall hug, perfect. And now you want to add marches? Cool, keep adding the marches and have them not compensate, right? And that's tough. So I'm taking one thing out, but I can still regress now the shoulder by taking off the load there, but I'm still adding an isometric hold onto the shoulder. So it's just like, I guess, quick movement like that, like quick off the...
Sometimes it's hard to like get them to understand stiffness.
Stiffness?
Like if I'm pushing you against the wall to try to get you there.
Yeah.
Just like, oh, this is too easy. I'm like, it shouldn't be that easy. This
Right.
is me, you know?
Right.
Yeah.
Yeah.
It's like,
Having them understand the value of how you like
like
made
not
something.
Just do the movement, just not just hold the wall, just to hold
Yeah.
It's gonna be an easy exercise if you do it wrong. But like,
Right.
is there a cue or a way that you teach stiffness more? Like, how do you push yourself back? Into
Like an ISO? Like an isometric, basically.
Yeah.
Yeah, I mean, you're right, that is tough. A wall like that, the second I'm doing an ISO against it, I feel it. If they're not feeling it, I'm giving them something where now it's not just the wall. For example, whether it's a foam roller, now that foam roller is behind your hand, and the second you let that foam roller go, I know you're not holding it, right? So that I would give some cue like that where the second they drop, something's literally moving and you can't see it. Kind of how when you're working on pronation of a foot, you put that band under the toe to work on toe drive. The second that toe snaps, like the band snaps, right, we don't see it happening. So I would just add things like that to where there's something that they're almost holding against. So that's why I was saying, when I was saying the neck one, I put like a small ball right behind here. And the second that ball drops, that means that they weren't doing an ISO hold. They say it's easy, yeah, because they weren't firing the muscles. So just something where it's like they got to kind of hold it against to be able to have a visual cue as well as a tactile cue, kind of, yeah.
So how much space between the wall and them, or are they trying to squeeze the whole back to the wall?
Right, okay, that's a good point. So naturally, everyone's spine is different, right? I have way more thoracic, it's called kyphosis. I have a lot of thoracic kyphosis. I have some lumbar lordosis. So for me, it would be unnatural that my whole back is going to be straight. But the biggest things I'm thinking, right, are our cues, shoulders down and back. So if my shoulders are down and back, and I'm doing a posterior pelvic tilt, I still have a little bit of space. Are they feeling it in their rotator cuff? I'm asking them, do you feel it behind your shoulders? Yes. Do you feel your neck extensors turned on right now? Yes. There's actually a ball right there, right? And the ball's not dropping, so they are doing that. Do you feel the TA drawing? You can ask them yes, or you can palpate it yourself now, right? Because now you know what it feels like. If there's still a little bit of space behind the back, that's okay, because everything else is still doing what we want it to do. When it would be too much is if you put your hand back there and there's like so much lordosis, and then you're now palpating TA and you don't feel it. Then that's when I'd be like, okay, that's too much. Stuff like that, yeah. But we're going to definitely hop around this, because all the other stuff is kind of sciencey and not that important. But any other questions? I think it's good to keep just asking questions on it now.
Back in the flat back.
Yeah, flat back syndrome.
So how do we cue them differently, whether it be a squat or deadlift, when they have a flat back?
Yeah. So flat back, when you think about flat back, we're thinking about the muscles that are being lengthened. So it's your lower erectors are being lengthened, your glutes are being lengthened. I honestly haven't seen many people with flat back. I'm glad you guys have. I haven't seen any people with flat back, so I haven't really
You
had
don't get a lot of those, I feel like, in general, right?
flat back, not that much.
I
No.
want to pay attention to it more now because I think
Yeah.
Curious.
Well, I mean, I guess it just depends what in the movement that you see is off, right? So like, try to give me an example, just because it's like very broad.
I mean, if I'm thinking of flat back, they're probably gonna lean more forward with their toes, right? Like just to get.
That's so right. So the reason you lean wherever there's a weakness. Okay, that's actually something, do you guys understand that, like in general? Is that normally how it's taught, right? You lean wherever there's a weakness. So if I have glute med weakness, do you guys know what like Trendelenburg is? So people with glute med weakness. Your glute, the job, I'm going to answer your question. I'm just making it full circle. Your glute med, the job of your glute med on this stance leg is to keep this pelvis neutral, right? If someone's walking and they do this, they have a weak right glute med, their pelvis drops every time they step on it, and they don't have the strength in that glute med to keep this pelvis up like this. And you'll see it a lot with some of our older clients. They drop like this. They drop, and they keep doing that movement, and it's that right glute med is weak. So when you're thinking there, so what they do is they lean towards that weak side to help keep that pelvis up. And it doesn't look that dramatic. That's the hard part, is it could be something super small like this, where you don't really see it, and you're like, oh, maybe their ankle hurts, maybe their knee hurts. Like you start thinking about everything else, not really the root of where it's coming from. So there, you have flat back syndrome. I don't want to call it syndrome. You have flat back. You have long, lengthened erectors, lengthened glutes. They would actually probably lean more back, not lean forward. They're going to lean towards where they're a little bit more weak, because since their back's not holding up, they feel like they have to now shift their weight like this to hold it. And they would go completely down. Like my toes are going to, yeah, my toes are going to completely go back. Same thing with quads. If someone has weak quads, whether it's a nerve problem, what they do to keep that up, they're going to, it's called jackknifing. So what they do is they kind of lean forward. They're going to add the weight forward to kind of hold it, because they can't do it on their own. Does that make sense?
A little bit,
A little bit?
What would you see, how would you see it in a movement, not just walking?
In a movement, not just walking. If you're here,
Like how would they squat, how would they lunge?
let me think. So then here, if I'm saying you go towards the weakness, then they would go forward on that one, on a quad, right? Weaker quad. No, they'd probably lean back. What do you think? A weak quad.
we call it, they would hinge probably more.
I would think they would
Hinge more. And they're hinging. So when we hinge more towards, and they're basically going towards their weakness, right? So they're going here now, right? Now we're here instead of back here, because here my quads turn on way more when I try to hold here. And now here, yeah, I'm going to hinge forward. So yeah, that was good. As a group, we kind of answered that one. Good. Thank you, guys. Towards the end, I'm like, oh. But yeah, so you're leaning towards, you're compensating. You're like, okay, I'm weak. It's not letting me hold this up, so now I'm going to shift towards that side that I'm not really able to hold it on my own. And like I said, those are things in school, it's like they drill it in our heads to look for. So it's going to be hard, even if I'm like, kind of, we're discussing, oh, what are some of the main things we see? It would take probably some time, like, as a, you know, for it to be cohesive and like we're all seeing the same thing. But
I just want to quickly give the coaches space, because I asked them to
Yeah.
come with like examples
Oh,
of
yeah.
questions or things. They don't have any questions they want to talk to Angela about, or clients they want to talk about?
It's just a Kyle K thing, something like that. Like, what?
Yeah, like, I guess what should I,
Yeah, once he's fired, he's off the rower, he's done.
Yeah.
Like, we were talking 10 minutes into the workout.
and that happened. Okay, and
What is your first like go-to for something?
first thing I'm doing, right.
Yeah.
So first thing I'm asking is, where did it hurt? Did it hurt on the pull back, or did it hurt on the way forward?
Pull back.
On the pull back. So once he's going into extension. Right, okay, so extension's hurting him. So what other movements does the spine do other than extension? It does flexion. That flexion actually might make it feel better. So if that's the case, I'm going to have him sitting like this. I'm going to get a ball. You guys have a Swiss ball or something like that. I'm going to have him start doing forward rolls. Something as simple as that. Just asking, does this bother you? No, it doesn't bother you. Okay, so flexion-based exercises aren't bothering him. So then I'm going to break it down like that, because I don't want his session to be done, right? And any movement is good movement.
So I had him do, when it happened with me, I had him do like a modified eccentric setup that we use.
Modified
because
eccentric, okay.
I've used that in PT for my back.
Yeah.
Or basically just in, because that's what my thought was flexion.
Right.
I just had him sit here.
Good.
And like slowly.
Yeah.
Like this.
And how'd that feel?
And he did all 5. I just said, do 5.
Yeah.
He's like, that was way worse. I was like, oh, great.
Okay, yeah. So that is good. You think a flexion-based exercise, but what I would do before you gave him that is, obviously, what are we going to do before an eccentric, right? What's even like more like regression than that? Something concentric, right? So that's great. Immediately, you're like, extension bothers him, let's do flexion, but I'm dumbing it down to going constant, even in ISO. Even if it's just an ISO, even if it's him, I don't know, you could do against a wall, having him like a ball right here and pressing against doing flexion, doing some sort of ISO. You go, right, ISO, concentric, then we'll get to eccentric. And I don't think he'd feel like it's a waste of his time, right? It's like, okay, they figured out which movement helps me feel better.
Trust what you're saying. So
Yeah.
you can try anything.
Yeah.
You just obviously like kind of what Pat's communicating way.
Right.
Like, it's
But I would
10%.
break it down.
Shit, I have this whole workout plan.
Yeah.
I don't want to just give him tricep extensions for
Yeah.
Right. Well, I would break it down into that, and then I would immediately put some sort of core stuff in there, like the co-activation stuff. Yeah, you're not doing much. It's basically an isometric back extensor, actually, like a bird dog. They're not really going to extension. It's just an iso, and then their arms are moving, right? So I would regress to one of these, like completely, and then see which movement.
So you don't like I know him and I talked about it. Like he connects it to his hamstrings because he has extremely tight hamstrings. And of course, like we work on the mobility of the hamstring, but he thinks it's because of his hamstrings, and then that's pulling his back.
So if he has tight hammies, what's happening at his back? Are they lengthening or are they shortening? Low back.
They're lengthening.
No, they're short.
They're shortening. Yeah, they're shortening.
Wait.
The hamstrings.
Hammies? No. When hammies are pulling down, what's happening to low back?
Extension.
Is it?
I don't know.
No, I don't think
Pulling on
so.
the low back muscle, correct?
You're pulling it. So it's lengthening it. Now they have that flat back, right?
Correct.
So it's lengthened,
Yeah.
not shortened.
No,
They got
extension,
the hammies.
not flexion.
Say that again.
Extension, not flexion.
Yeah. Well, no, what I'm saying is how are the muscles when
They're lengthened.
they're
Because
lengthened.
the hamstrings are pulling on them. They're pulling on the pelvis.
Right.
Okay.
So now he has long low back muscles, right? Long. They're lengthened, they're weak.
Correct.
They're not at the right tension that we need. And he says, what does he say he thinks it is?
He's basically saying because his hamstrings are so tight, he's injuring his back because his
Okay.
hamstrings aren't like functioning correctly, right? Yeah.
Right.
I think his thing was like, if my hamstrings are tight and I'm pushing with my legs,
Right.
I'm lengthening the low back.
The low back.
But then he went to go add the row in there.
Yeah.
Yeah.
And then you think about it, when he's in this spot, that's the most length in his back can be, right?
Right.
His
So,
hamstrings are pulling.
right. So then I'm thinking, well, the way I'm bringing that down is he training in a range where he's always starting from a super lengthened position and then just being from that range to middle? Do you guys do exercise like that with him? So I'm trying to think of something that could be like that. But so for example, the first part of the row is going to be here and here. Does he do much movement in this part of the row?
I honestly don't know if it would have happened at all if we didn't row.
Right.
Right. But I'm just saying when I
Yeah.
think about that, that's what I'm thinking. I'm
That could've
thinking
been
all.
triggered.
Yeah, I'm thinking about all parts in the range.
Yeah, yeah.
Which is also why, like, the third row, like, third rep, it was.
Yeah.
He also goes max intent.
Well, that's.
Yeah.
That's another part of the story.
That's another part, okay.
Yeah.
But that's another big thing too when you guys are thinking about like where they're having these things at. It's like it doesn't always have to be an exercise through the whole range of motion. Like find that part where they're weak and like hammer that one in a bunch. So like with someone like that, I would probably, first couple of exercises I do with him, it'd probably just be in that first half of the range. Kind of how we do totally different kinds of hammy stuff. It's not just your full length of the hammy, it's the first half and the last half, and now we're adding plyos and doing quick eccentrics. So yeah, just like, I don't know, I think that's helped with me a lot is when I really kind of just make those little adjustments and someone says they're feeling better, I'm like, then I'm running with that. And then it usually is like the little difference that does make them feel better, like things like that. But it does take time. And like I've obviously haven't been doing this a lot. Like you guys have so much you can teach me too. So it's like, I don't know, it's.
Cole, did you want to ask? Oh, go ahead, Sam.
Yeah, does it make sense to do self-myofascial release if that happens?
Well, it depends. If it was a pull, I wouldn't do it. If he thinks it felt like a pull, I probably wouldn't do a self-myofascial release because it's not a trigger point. I'm doing that for a trigger point for a muscle that's super tight and a knot. And that's what I'm feeling for, right? So that's why I ask people, if they come in for hammy and they're like, oh, I felt like I pulled it, I'm not going to stretch the crud out of it, right? That wouldn't make sense because they felt that pull. So also that's a good point. Like think of what they're saying. If they use the word, like it feels like a knot or something like that, all day I'd be like, yeah, I'm going to start teaching them myofascial
But that
things.
was like, for him, that was like an acute, like, I'm nauseous, I just injured
I
myself.
wouldn't do that. No, I would find the movements that feel okay and just have them run through those.
I also forced ibuprofen down his throat.
That's good. You could do that. I can't.
Well, I mean, like, I just.
No, you literally can't. I can't.
I motivated him that it was.
No, yeah,
good
it's fine.
To get on the.
Yeah,
if
absolutely.
It was something bad. Like
Right.
Inflammation.
For sure.
Yeah.
For sure.
Cole, did you want to ask about DJ?
Oh, sure.
Yeah.
DJ's gonna have flat back.
What?
So it seems like a lot of people might have flat back. And we're thinking about flat back the right way, right? If your hammies are tight, your low back is lengthened. I just want to make sure I'm saying that right. And we're,
Yeah.
yes, okay, good.
The way I see DJ is he kind of like doesn't have that flexion. He just kind of like.
Does he just break?
He does
Like
not control
yeah.
it.
Okay, he doesn't control it, and he kind of just breaks.
It feels
No,
like
like
his torso is kind of longer than his legs
Like
too.
if he can't.
Segmentally roll.
He just,
Yeah.
right, he can't like flex his spine.
So he can't segmentally roll his spine?
That's what I think you're trying to do,
Yeah.
yeah.
Okay, so you say that, I immediately get him on a treatment table, or you guys check his mobility, right? You're looking at each vertebrae, have him hold his chest, look at each vertebrae on the way down, and if you guys can see there's not good movement here, great. If you can't see it, I can look for it. I see where there's a hypomobility. Now we're not talking instability. Now we're talking like a mobility problem, like less mobility. And then that's where you're making it more of a mobility protocol instead of a stability protocol. So that's where that question is a loaded question, and it's hard to
Oh, what were you
Kinda.
saying with his pelvis? You said something with his pelvis.
He like does not control it well.
How do you see that?
When he squats, when he does bird dog, when he does a hip thrust, because I cue him a lot on it.
How do you see him in squats?
He like butt wink, like bad. Like it's like a quick like it.
the butt wink at the bottom.
Yeah.
Is that what you're talking about?
Even
Okay.
from controlling depth?
I played around with a lot with him. I've only been with him a couple of days squatting though. Depth I've worked on. That I had him slow tempos down helps. I had him be aware of it. I tried. It's gotten a lot better. Like
Because he cancels a lot because of his back.
because his hip thrust or his elevated hip thrust with me, like he said it was something that bugged him in the past, and me and him worked on it really hard, and he said it was the best it felt. So
Yeah.
he just doesn't control his pelvis though. But I also don't. But he like tweaks his back all the time outside of here.
Right.
Like
But then,
He sees a physical therapist regularly.
now it's periodic checkups.
And it's Pilates he's doing.
Yeah, but I think he's like really focused on stability aspect of that, not mobility.
yeah.
I said I'd love to test his hip range too because
Yeah, that's exactly, yeah. That'd be good.
But yeah, he's a tough. I feel like I haven't had him pull it in here yet with me, but well, besides the first time I met him, knock on wood.
It's that first day.
Yeah.
And then, but he pulls it all the time outside of here.
Yeah.
Like all the
Well,
time.
just to add something with that, if any of your people where it's that low bottom part of the squat where they're having problems, how are you guys regressing that?
I mean, I'll reduce the range of motion.
So you're having them right at that bottom range? Continuously doing stuff at the bottom range?
No.
Okay.
Keeping them above.
No, see, no, what I want to do now is I want to work in that range. There's your problem, we're working in that range. Whether it's,
It's like a deadlift.
because it's now we're avoiding the problem, right? You have a butt wink at the bottom, okay, let's just not get to the bottom. Well, no, let's get to the bottom and let's see where it's not working and let's work in that range, right? So if that even means come here to a box and this is where they're starting and this is their cue, come off and now we're working here. Here, come back. Like literally just things like that. Yeah, you know what I mean? Like I want to work them in that range, like be in that spot. What are you doing that face for?
It's really hard.
Oh, well, yeah, but then they'll feel it. They'll feel it where you want. You know what I mean? It's like,
So how do we know, like, I guess if he's vulnerable in that area, what happens if we do something like that, he pulls it?
yeah, well, that's the scary part of all this. That's what, yeah, that's,
Okay.
trust me, being a new PT, when people kind of like, how do you feel? And I'm just like, don't say worse, don't say worse. Because you're testing it. Like you are testing a new thing for them, right? But that's like how it is. That's how anything in medical is too. That's how a doctor prescribes medicine. They can be like, no, you're so off. I don't feel better. So it's just, that's with time and with repetition of seeing, oh, this one did work, right? So.
I guess in the same aspect is, how do we know pain? Like, what's good enough to be, let's keep working through that, and
Yeah.
it's not, like, a number RPE scale, or?
Yeah, so I mean, we use a 0 out of 10 scale, but I don't even like asking people what is your pain right now out of 10, unless I really have to ask it, because I'm just training their brain to go and feel and try to understand what their pain is at, right? So it depends the kind of person. Like when I work with her, pain isn't limiting her. She's just like, okay, I didn't feel right or whatever. And then if it's really painful, like I know if she's really in pain, she'll stop. With other people, it just depends your verbiage. Like I tell people, I'm like, I want you to talk to the pain and then come off the pain. I don't want you to sit with your pain. So if it's like a squat and we're working at the low range and you feel like you're sitting with your pain that whole time throughout that movement, we shouldn't be doing it. But if you feel like you just get to a point where you're kind of talking to the pain and you get off of it, I'm fine with that. And like a lot of people do kind of resonate with that because they're like, okay, I did kind of feel it for a second, but then we went away. So it's just like finding the right verbiage to where they're like, it just kind of makes clear sense for you and for them, right? Because you don't want to push them past it too much either. So
I feel like that's how I work. Is that how you guys work? Or you let people be in a little bit of pain?
I let people be, yeah. If it's acute, no. If it was the guy on the rower, no.
Oh, yeah.
If that movement kept, no, yeah. But if it's someone that you've been, yeah, right. Yeah, exactly. So it's just, yeah, it's figuring that out. And obviously y'all know your clients more like well enough to kind of be like, all right, this person always says it hurts. Or no, this person like really doesn't go through that much pain. So that's the art of it, is understanding pain.
Anyone else have any questions before Roger asks his last question?
Do you think we would benefit a lot from table tests?
Table test? Like
Like what you just, like a range of motion, like passive range of motion?
yes, I think if there's a problem that hasn't gotten better and you keep drilling exercises to them and we now think it's a hip problem and I take their hip range of motion and I see there's a huge limitation and now we work on that and then you see a greater improvement in the hip and they feel better, I think it's amazing. I think that's like literally.
Do you think it is out of our scope to test and retest?
Range of motion and stuff?
Uh-huh.
I mean, that's a great question.
'Cause I've always been unsure about that one.
Yeah. I don't.
And the place I was at prior, they did it.
Where were you at before?
Cressy.
You were with Cressy, and they have personal trainers testing range of motion?
Yeah, we did it all the time.
Okay.
Yeah, we did it all the time. But then I meant more like the test retest. Do you think that as long as it's not pain, do you think it's out of our scope or no?
To basically clear them and be like, oh yeah, you are getting better?
Or like, let's say we have a feeling that hip IR is causing something to be wrong.
Right.
Let's try this exercise, or let's test passive. Let's try this exercise.
Yeah.
Test. It got a little bit better. Let's stick that exercise in.
No, I think that's great.
Okay.
I think absolutely. But do you think that you have a solid enough foundation to feel hip IR and feel, is this a muscle restriction? Is this a bone restriction? Is this a ligament feeling? That's then my question. When you're passively feeling something, because passive, cool, I can look at it, it looks fine, but that doesn't feel right. Yeah, so if you.
I have a small basis, but I think
right.
it needs a lot of improvement.
Right, and then that's the biggest thing, I think, which is the big difference, is like, right, I have to put my hands on someone every single day, so I am feeling what normal feels like and what abnormal feels like, just because I get to do it every single day. So I think that would be the only big difference, is does it feel like a normal hip? Does it not feel like a normal hip? But I do think, yes, you'd be able to assess, reassess, if it's like, oh yeah, it was a little bit of IR, we tweaked that, and then it was good. But yeah, I think
Or
the
even
only.
just to like decide if this is a good exercise to give somebody. 'Cause
Yeah.
Like IR, let's just say like we give them a.
Like you did that functional screen, you see it, and then now you.
And then let's say you gave that to me.
Yeah.
It's better, perfect. Let's. Put
Yeah,
it together.
absolutely. I think for sure. I think that's like kind of why I wanted to show you guys the functional stuff, because that's something on site you can do it and then do your assess, reassess. Yeah, for sure. I think that'd be huge.
Yeah, I think that's totally clear.
Totally
to
clear.
a personal trainer.
Yeah.
I think it's more the other stuff that becomes more like
A little iffy.
I can't, like you're saying, like if you palpate someone every day, you get really good at it.
Yeah.
But like I don't necessarily know what I'm
Feeling what you're.
when I
Yeah.
palpate someone.
Exactly.
I think.
Oh, it has to happen once. At least it wasn't mine. I'm kidding. But yeah, no, it's good.
And I know in the state of Florida, like rules like that are like very lax, but like of course we want to be professional and like
Oh yeah,
stay within our boundaries.
for sure. I'm
Any
getting my
more
drink.
questions?
I know you talked about me and Heather about
Uh-huh.
routine with this and bulging.
Yeah.
And we have a lot of clients that come in. And
Yeah.
We use that as I'm very afraid of my back.
Yeah.
Is there a way you would handle that to educate the client on like, hey, this is very normal?
Yes.
Okay.
So if it's an older, no, you're fine. If it's, you're totally fine. Yeah, well, what I do say is you just got your MRI, however old they are, whatever. You just got your MRI. This could have happened to you when you were 40 or when you were 30 actually lifting your kid from the ground to the up. But just now that you got your MRI and now that you're starting to get low back pain, which is something that does happen when we get older, now you're thinking that's the root cause of everything, and it isn't. There's a lot of other things, and then you're showing them, this is where you have instability. This is where you have weakness in your back or your hips. I just kind of like try to tell them that it's not always that that's the root cause. That's how I'm educating my clients on it, you know?
Take the fear out of it.
Take the fear out of it, yeah. Like, I mean, like, for example, like my knees been bothering me so much. This probably happened when I played soccer when I was 16, and now that I'm not doing knee stability at all, and now that I'm trying to run way more than I probably can, now it hurts. But if I go get an MRI and check my meniscus, I'm like, oh my gosh, it hurts so bad now because my meniscus is sprained. No, that happened a long time ago probably, right? MRIs can't tell you how soon or how acute or how chronic something was. So I just kind of try to relate it to that. Like, you've been moving this whole time and doing good. This isn't the root cause of your problem. Like, there's so many other things, and that's when having objective values is awesome. There's so many other things we can show you that is maybe why you're having this problem. Or we can be confident and say that is why you're having this problem, instead of just all they have now is an MRI. We can give them so many other values to look at other than the MRI. It'll cancel out the thought of the MRI, you know? So I think, yeah.
Thank you so much, Angela.
Of course. Thanks for listening, guys. Here, take your mic.
Yes, yes.
I don't leave it.